Welcome, and let's jump right into this deep dive focusing on orbital floor fractures. For the plastic surgery resident and attending, this isn't just anatomy, right? It's really about critical decision-making in trauma. We're unpacking the evidence on diagnosis, surgical management, really pulling out those clinical pearls you need for practice and, well, for board prep too, starting right now.
Exactly. Our mission is pretty clear. Synthesize the foundations and, the nuances of managing these injuries. We want to guide you through that decision path, especially around things like acute entrapment and the factors that predict long-term enophthalmos.
Okay, let's start with the basics. The foundations, the bony orbit.
Mm.
It's kind of a pyramid shape, right? Total volume is approximately 30 milliliters. The globe itself only occupies about 7 mils.
And its location is just crucial. The orbital floor is the roof of the maxillary sinus. That's exactly why we get that classic blowout trajectory downward.
Right. In that position, it creates the different fracture classifications we talk about.
Yeah, you've got the impure blowout fracture. That's where the orbital floor fracture also involves the inferior orbital rim. You see that a lot with ZMC fractures, the bigger zygomatico-maxillary complex injuries.
And then there's the pure orbital floor fracture.
Right, the pure one. It occurs in, maybe 22 to 47% of orbital injuries. The key there is the rim stays intact.
Now, where the clinical relevance really hits home, I think, is this mechanism debate. For decades, we were kind of split, weren't we, between the buckling theory.
Force transmitting from the rigid rim down to the weak floor. That was Lefort back in 1901.
Versus the hydraulic theory. Pressure from the globe itself getting transmitted to the bony orbit. Pfeiffer, 1948.
And what's really fascinating is that the recent evidence shows both mechanisms happen. They just produce different predictable fracture patterns. And this brings us to our first clinical pearl, really. Understanding the mechanism helps you predict the outcome.
Okay, so how does that break down?
Well, if the mechanism was likely buckling, you typically see smaller, more linear fractures, usually along the anterior part of the orbital floor. These have a pretty low likelihood of resulting in, clinically significant enophthalmos later on.
But if you suspect the hydraulic mechanism.
That's different. That suggests pressure transmission caused a larger, often more posterior fracture, frequently involves both the floor and the medial wall. So with that pattern, you see herniation of orbital contents much more often, and there's a significantly higher chance of delayed enophthalmos.
Got it. That makes sense.
Precisely. And the mechanism is also key in understanding maybe the most acute crisis we face, the trapdoor fracture.
Oh, yes, the trapdoor.
It's a pure orbital floor fracture, but a specific type where a medially hinged fragment, like a little door, transiently displaces downwards, contents herniate through, and then it snaps back, and trapping those orbital contents.
And that entrapment is what locks up the eye movement, right?
Exactly. It's the inferior oblique and the inferior rectus muscles that most commonly get caught. That leads directly to that acute restriction in upward gaze and, of course, diplopia. That situation demands an immediate diagnostic workup.
Absolutely. Okay, so let's shift focus then. Diagnosis and evaluation. The trauma patient comes in. Beyond the obvious stuff, the bruising, the swelling.
Yeah.
What are the key objective signs you're looking for?
Well, you're looking for localized pain, obviously, subconjunctival hemorrhage, that blood in the white of the eye. Diplopia is a big one. And always check for sensory deficits in the V2 distribution. That infraorbital nerve, hyposthesia, numbness in the cheek or upper lip.
And we absolutely have to objectify the globe position.
Yeah.
Enophthalmos, that posterior sinking of the globe. It's noticeable clinically at just 2 millimeters, right?
That 2 millimeter threshold is so critical because research shows just a 5% increase in the total orbital volume is enough to cause clinically significant enophthalmos down the line. So if those lateral rims are intact, you really should use the Herter-Hest ophthalmometer. Get a baseline measurement, compare it against the unaffected side.
Visual assessment,
That's it.
non-negotiable, beyond just the basic acuity chart.
Yes. Assessing color perception is vital, specifically looking for a loss of red saturation, like reds looking faded or washed out. That can be one of the absolute earliest signs of a traumatic optic neuropathy. And that needs urgent attention, maybe ophthalmology involved quickly.
And the pupil exam.
Crucial. You're looking for an afferent pupillary defect, an APD. That signals optic nerve injury. You check it with the swinging flashlight test, right? You watch for paradoxical dilation of the affected eye's pupil when you swing the light over from the unaffected constricted pupil. If that pupil dilates instead of constricting when the light hits it, it means the nerve isn't sending the light signal properly. Big warning sign.
Okay. And what if the patient can't cooperate? They're unconscious, or maybe it's a child, or we're just not sure if it's true entrapment versus just swelling limiting movement.
Yeah, in those cases, force seduction testing is still essential. It directly assesses the mechanics of the astroocular muscles. Although for us as plastic surgeons, you need to remember this really requires sedation or anesthesia. It's not comfortable for the patient otherwise.
Right. Makes sense. And all this clinical assessment leads up to the imaging, the CT scan.
Correct. Coronal CT sections, ideally thin slices, 1 to 2 millimeters, they remain the gold standard. They're definitely the most useful for accurately seeing the fracture size, the globe status, and any definitive evidence of soft tissue entrapment or herniation. And sagittal reconstructions. They're also really helpful for pre-operative planning. Helps you visualize the orbit's original shape before you try to reconstruct it anatomically.
I see. So you've got the CT scan back. Now, the really crucial question for surgical practice. When exactly are we deciding to go to the OR? What are, say, the three most important factors driving that operative management decision?
Yeah, those three are paramount. Number one, the degree of enophthalmos, especially early on. Number two, the impairment of ocular motility, particularly diplopia in primary gaze. And number three, the radiographic findings themselves, fracture size, degree of herniation, any muscle rounding.
We need to be really precise about the timing here. Immediate or urgent repair, meaning within, what, 24 or 48 hours? When is that absolutely mandatory?
It's mandatory for several critical indications. These include early enophthalmos greater than 2 millimeters right off the bat, also defects that are larger than 2 square centimeters or involve both the floor and medial wall significantly. Those are very likely to result in delayed enophthalmos if you don't fix them. And critically, pediatric trapdoor fractures, the so-called white-eye blowout fracture, that's an emergency.
And entrapment.
Absolutely. You must explore immediately when you have CT evidence of muscle or tissue entrapment, and it's associated with symptomatic diplopia, significant gaze restriction, or a non-resolving oculocardiac reflex EOCR.
Ah, the OCR. That's a true surgical emergency.
If
Remind us quickly of the mechanism, because this is potentially life-saving, knowing this indication for urgent repair.
Yeah, the OCR is triggered by pressure on the globe itself, or more commonly, by the incarcerated soft tissue pulling on the muscles. This triggers increased vagal tone, afferent is V1, trigeminal, efferent is vagus. It manifests as bradycardia, a slow heart rate, sometimes even junctional rhythms, or rarely asystole, plus nausea and vomiting. If those symptoms don't resolve pretty quickly after initial assessment, maybe some gentle maneuvers, then immediate surgical exploration is required to release the trapped tissues and relieve that vagal stimulation.
Okay, so that covers the immediate stuff. But what about the patients without those really acute, urgent indications? We often talk about delayed repair. This is where the diagnostic subtlety comes in, isn't it? And this leads us, I think, to clinical pearl 2, focusing on predicting that late enophthalmos.
Correct. So while fracture size is important, most surgeons will operate for defects larger than, say, 1 to 2 square centimeters, or maybe greater than 50% of the floor. You absolutely must look closely at the inferior rectus muscle on that coronal CT cut. If you calculate a height-to-width ratio for that muscle, and it's greater than 1.00, that rounding indicates significant muscle displacement or edema. That ratio is a strong radiographic predictor of late enophthalmos, meaning 2 millimeters or more is likely to develop later, even if it's not apparent initially. Though interestingly, this ratio doesn't seem to correlate well with persistent diplopia, just the globe position.
That finding is so key for counseling the patient, isn't it? One who might have okay vision now, but you know there's likely an inevitable long-term cosmetic issue brewing if you don't intervene.
Exactly. So delayed repair, usually within about 2 weeks to allow swelling to go down, is reserved for patients without those acute symptoms. And during that follow-up period, what are you watching for? You're looking for delayed enophthalmos or hypoglobus greater than 2 millimeters developing within, say, the first 6 weeks. You're also watching for persistent symptomatic diplopia, especially in that central 30 degrees of gaze that remains associated with CT evidence of entrapment or a positive force duction test once the swelling is down.
Okay. Let's move on to the technical challenges now. Surgical access. We know the subciliary incision. High risk of cicatricial atropium pulling the lid down. Many surgeons have moved away from it. When you compare the other approaches, say for a younger patient wanting minimal scarring, the transconjunctival approach seems popular, right? Even if it might need a lateral canthotomy for exposure.
It is popular, yeah. The big advantage is no visible skin scar and generally low complication rates. But yes, exposure can sometimes be limiting without extending laterally. But interestingly, the subtarsal incision, that's the one in the crease just below the tarsal plate, it offers very direct access. And some surgical literature reviews actually suggest it might have the lowest revision rate overall, despite the potential for a visible scar if not closed meticulously. It really depends heavily on the surgeon's comfort and experience and the patient's priorities. But technically, subtarsal gives great visualization for floor repair.
Right. And once we're in, the material selection.
Yeah.
That's always a big discussion point.
Eh.
And the evidence isn't exactly conclusive that one material is definitively superior, is it?
No, it really isn't. It's kind of the real dilemma. Autologous bone, usually split calvarial bone graft, is often considered the criterion standard. Great rigidity, biocompatible, integrates well. But you have donor site morbidity.
Okay. And the alloplasts.
With the permanent alloplast, you've got titanium mesh. It's strong, provides excellent support, but it can induce quite intense fibrosis, which can make any secondary surgery much more difficult. Then there's porous polyethylene, PPE, or MedPor. It's adaptable, allows some tissue ingrowth. But be aware it can potentially form adhesions to exposed extraocular muscles if you're not careful with placement. Some use titanium coated with PPE to try and get the best of both.
And the resorbables? PLLA, PGA, those kinds of things.
Yeah, they're attractive, right? They offer support during the critical healing phase, then disappear. But they do come with a documented risk of, well, delayed enophthalmos if they resorb too quickly or lose structural integrity, or sometimes intense inflammation during the degradation phase. It's definitely a trade-off, biointegration versus long-term predictable stability.
And regardless of which material you choose, there's a crucial surgical safety point here.
Absolutely essential. Force duction testing must be performed again immediately after the reconstruction implant is placed, before you start closing. You have to rule out any iatrogenic entrapment. Make sure your implant isn't catching the muscle or restricting movement.
Good point. So, given all that technical complexity, let's pivot quickly to a special population, children. Why are their orbital fractures inherently different?
Well, pediatric bones are just more elastic, more pliable than adult bones. This leads to a higher incidence of green stick fractures, and specifically those trapdoor fractures we talked about. The bone bends, traps tissue, and snaps back. They often present with what's called white-eyed blowout fractures. Minimal signs of trauma around the eye, maybe no obvious bruising or hemorrhage, but severe entrapment underneath, often from sports injuries or falls.
And their clinical presentation, particularly with the OCR, can be different too.
Absolutely. That oculocardiac reflex tends to be particularly strong in children. It often presents primarily with just nausea and vomiting, maybe some lethargy. The bradycardia might be less obvious initially. So you have to maintain a really high degree of suspicion, especially since kids might not reliably report double vision or cooperate well with an eye movement exam.
So the management timing for kids is critical. Early surgical intervention, say less than 48 hours, is generally associated with lower rates of persistent diplopia. But there's a key caveat, right?
Yes, a very important one. That early surgery benefit really only holds true when clear clinical signs of entrapment are present alongside the CT evidence.
Okay.
And that leads us nicely into clinical Pearl 3, in the absence of acute entrapment or clinically relevant enophthalmos again, that 2 millimeter mark or significant vertical dystopia where one eye is lower than the other. Pediatric fractures, even with what look like large bony defects on CT, can often be managed conservatively. Their remodeling potential is significant.
But if we do operate on a child, growth considerations are absolutely paramount.
Hugely important. Using rigid, permanent alloplast like titanium mesh may restrict normal midfacial growth as the child develops. Therefore, resorbable materials or autologous biocompatible grafts like split calvarial bone, assuming the diploic space is sufficiently developed, are generally the preferred choices. Minimize that potential for growth restriction.
Okay, let's wrap up by briefly touching on complications and maybe some modern advancements. Post-operative complications. They're unfortunately not rare.
No, they're quite common. Persistent diplopia, even after repair, can occur in, well, studies show rates up to maybe 52%. Infraorbital nerve dysfunction, that numbness, up to 55% initially. And persistent enophthalmos, despite surgery, up to maybe 27.5%. The literature does consistently show, however, that immediate repair for the right indications generally reduces these complication rates compared to delayed repair.
And we also see issues related to the surgical approach itself, lid problems.
Yes. Lower lid retraction or ectropion is seen in maybe 2.6% of operated eyes. That's significantly higher than unoperated eyes, obviously. And you also see an increased incidence of scleral show more white, showing below the iris in operated eyes, around 14% versus maybe 4% in unoperated controls.
So what's driving these issues, particularly the late enophthalmos or globe malposition, even after repair?
Well, a primary driver for many of these late complications seems to be anatomical inaccuracy during the initial reconstruction, specifically unintentional bony orbit enlargement. That occurs in about 8.5% of traditional reconstructions. The implant might not perfectly restore the original volume or shape. This is where modern advancements are really trying to tackle the problem head on. Things like detailed preoperative CT scanning, virtual surgical planning, VSP, using stereolithographic models to pre-bend implants, and importantly, intraoperative navigation systems. These are all becoming essential tools to achieve more accurate anatomical reconstruction and hopefully better long-term results.
Okay, fantastic overview. Let's try to unpack all of that with a brief recap of our plastics and practice summary.
Yeah, right.
For the surgeon listening, what are the three most critical, immediate clinical takeaways for managing orbital floor fractures?
Okay, three key things. One, triage and timing. Immediate repair within 48 hours is mandatory for any patient, but especially a child showing clinical signs of entrapment, like diplopia or gaze restriction, or symptoms of the oculocardiac reflex. This holds true regardless of the absolute fracture size on CT.
Got it. Number two.
Two, diagnosis confirmation for delayed issues. If you're evaluating a patient for potential delayed enophthalmos, remember that inferior rectus muscle height to width ratio on the coronal CT. If it's greater than 1.00, that's a strong predictor that 2 millimeters or more of an ophthalmos is likely to occur eventually. Helps guide that delayed repair decision.
Excellent, Pearl. And number three.
Three, material selection in kids. In children, you absolutely must prioritize materials that won't restrict facial growth. So think resorbable plates or autologous bone first over permanent alloplasts like titanium or solid PPE.
Perfect summary. This actually raises an important final question for us to think about. Given the increasing accuracy we're seeing offered by virtual surgical planning and intraoperative navigation, how might that technology potentially change the indications for operating, specifically for those smaller, non-entrapment fractures, or maybe traditional, less precise repair carried a higher risk of iatrogenic complications like nerve injury or implant malposition? Could we be intervening more accurately and perhaps earlier for subtler defects in the future? Something to mull over until our next deep dive.